the room is filling up. This is really great. It's 7:35, so we're going to go ahead and get started. It is my great pleasure to introduce Dr. Steve Vanhoy. He is an assistant professor in the Department of Anesthesiology and pain medicine at the University of Washington, with a special focus in liver transplant anesthesia and subspecialty training in critical care medicine. Um, with all of that said, he's also a really lovely colleague and has been a POCUS champion at the University of Washington since I can remember, since I got there, really, which is really great when he was a critical care fellow years ago. So we're really excited to have him speak today on assessing the left ventricle and hope that you enjoy his presentation.
Awesome. Thanks so much, Sarah. So I kind of wanted to start with a little bit more basic talk about how we think about the left ventricle when you're coming to assess a patient who's unstable or you're just unsure based on a history of what's going on. So we'll kind of just jump right in. So I've got no financial disclosures. I wanted to put in, I got, a little bit about myself. I have two young daughters who are very sassy. We just got back from a conference, and they've been kind of the subject to some of my learning early in my POCUS career. And so they've been key into kind of being test subjects for me, trying to learn a little bit about this modality. So I kind of wanted to bring everybody to what did the first day of POCUS look like? And I don't know about everybody on here who had POCUS training, but I remember as a medical student walking into the ED, and this attending basically came up to me and handed me this ultrasound probe and said, "Have at it, bud. Why don't you go ahead and see what you find?" And I felt a little bit about like these young Padawans who were given very dangerous weapons, some lightsabers, and told to just kind of have at it. So, and when I finally found some structures, he said, "Oh yeah, just eyeball things, figure it out and go from there." And, it really struck me as if I'm really trying to help a person and make a medical decision about this, am I really the qualified, or am I saying that I'm going to be qualified enough to do this? And so there are some studies that have looked at this eyeball test, two of them here that I have cited, and both of them have taken visual estimations of the LVEF specifically, and they looked against cardiac MRI, which, is considered the gold standard. And they said, yes, indeed, there is some ability to correlate the findings on both of them. And it was interesting, they really noted that the more severe the dysfunction with the left ventricle, the more accurate the visual eyeball test was. So when we get to the more mild dysfunction, they gave a plus or minus of an ejection fraction of 8%, which in my mind, 8% usually isn't going to be the biggest difference, making or break a medical decision for a patient. But when they found very severe left ventricular dysfunction, it was spot on. It was like within 1% of, yes, this is a very bad heart. We need to do something to help it. So yes, I just want to tell everybody, this qualitative assessment is valid, and you can make real medical decisions to help patients out doing this. So most people, hopefully from this series, have a basic understanding of the views, which I'm still going to go over, and maybe we want to go through some review. And I've had some surgeons open up patients, and the residents I've heard, the surgical residents, have looked down on the patient and be like, "What am I even looking at?" And so as we kind of go through each of these images, there's three things that I think are really important in how I use qualitative assessment. So the first, I'm going to be looking at the myocardium, and I want to see, just like when you're making a bicep muscle, that you want to see that myocardium get more thick. I want to see the chambers of the left ventricle. I want to see that they're approximating, so how closely they're coming together. And then really, I'm going to do a more kind of global assessment. Is there asymmetry? So when I'm looking at the structure, is everything contracting the same on each side? And I'll go through and give some examples. So here we've got a very standard peristernal long axis view. And on the left, you can kind of see all the structures are labeled. And so I hope everybody can see my mouse moving, but At the very top, we have the right heart, which is the most anterior structure. And really, we're going to be looking at the left ventricle for this talk. So we have the aortic valve, the mitral valve, and really this big structure over here is our left ventricle. And so looking at those three things, I want folks to look at the septum here, look at the infralateral wall, and then looking at kind of how much these two are coming together. So you can see this is a normal echo. And so you see that there's some thickening of the myocardium, that the two walls are coming close toward each other, and that they're relatively symmetric, that both of these are contracting in the same way, okay? And in order to, as you guys know, in order to obtain these views, we're gonna use our phased array probe, left sternal border, somewhere between the fourth and sixth ribs, with the marker indicator pointed towards the patient's right shoulder. Okay, so another review. So here's our parasternal short axis view. Again, you're going to take the probe in that same orientation. You're going to rotate it 90 degrees to the patient's other shoulder, so to the left shoulder. And then you're going to see this short axis view of the left ventricle here. And so here we have our two papillary muscles that you can see. And again, three things. Is the myocardium thickening? So is the wall diameter increasing as the heart is transitioning from diastole to systole? Are the sizes of the chamber and are the sides all coming together and contracting in the same way? So if I move my marker right towards the center, specifically in this view, I find it very helpful to see if all of the walls are coming towards my my indicator in the center. And then is that there's any asymmetry. So if you say, hey, it really does look like one of the walls aren't moving as much as I would like, those are the three things that we're looking at for this view. Here we have a standard apical four-chamber view. And so again, left ventricle is on the right side of the screen, right ventricle is on the left side of the screen, kind of based on our standard views. This you're going to go on the left side of the patient, so left anterior axillary line, same fourth or fifth rib space. And then I'm going to have the indicator actually going posterior down into the bed into the patient. And that's usually how you'll find this view. So again, same three things. We're going to look at the walls of the myocardium. Is there adequate thickening? Are they symmetric? Are they approximating? Are all the walls coming together to try to create an adequate stroke volume for the patient? And finally, here's our subxiphoid view. And so this is, again, demonstrating we have the right ventricle most anterior and left ventricle here is most posterior of the ventricles. And you can see this one, I think, demonstrates it nicely. So the walls of the septum here are thickening on both sides. They're attempting to approximate here. So you have, and they're symmetrical at the same time. So things are coming together nicely in all these views. So these are very normal echoes, okay? So let's just jump into some cases so we can get some reps trying to identify how we can use it in certain situations where this modality might come into play for an anesthesiologist. So I work in the cardiothoracic ICU, and I use these techniques every day that I'm on the unit. And a lot of the residents will ask me is, hey, I'm not going into ICU. I'm going to be a humble anesthesiologist. Are there opportunities for me to use this in the perioperative space? Maybe that's not even in the operating room because the drapes are in the way and I can't get a really good view. So I'm going to give some cases that will be focused more on the ICU care, and then some that will be focused around the perioperative period. So the first case I've got is a 56-year-old patient who had a history of diabetes, hypertension, and severe aortic stenosis and went for surgery. They had an aortic valve replacement. Before the patient went to the operating room, they had a very normal echo, so very similar to the images that we just looked at. And their postoperative course is, in the first couple hours, things were going well. The patient was extubated, and then the resident and our team got a call about 4 hours later saying, hey, the patient's hypotensive, the urine output's kind of dropped off, and I'm having to go up on pressors. And you're called to the bedside to try to figure this out. And so rather than kind of jump right into the images, I kind of want people to get into the habit of, before they walk into the room, while you're getting your equipment set up, is what are you looking for? What are you expecting to see? I think it really helps kind of focus the views that I'm going to try to get with my point of care ultrasound to try to predict, say, hey, based on this patient's course and what I know about the history, what sort of things can I predict I might find, and then I can rule those out so I can move to the next step of the differential in the patient's care. So clearly you have an immediate post-operative patient. The very short differential that I want to rule out with my point of care ultrasound is things like hypovolemia. Is the patient hemorrhaging? Is there a tamponade? Is there a tension pneumo or hemothorax is happening? And much less likely, is there myocardial dysfunction? This patient had a pre-op echo that had normal biventricular function. Normally after these surgeries, it's still possible to have this, but it's unlikely. So I put it on the differential. So you walk into the room and the first thing you get is your apical 4-chamber view. And this is kind of what we see. So I'll give everybody a couple seconds to kind of eyeball this and see, based on the things that we were looking at, this is this scary, not scary, and kind of what our next steps are. So I'm hoping folks are looking at this and saying something's not right. We're looking at the different walls of the myocardium. We've got the septum here, and we have the lateral wall over here, that there's not a whole lot of thickening. There's kind of this dyskinesia going on. We really don't have, both of the walls are not really approximating as well as you would expect. And yeah, there's definitely some dysfunction here that's going on in somebody who had normal biventricular function prior. So I'm pretty concerned about what I'm seeing here, and I'll move to the next image. So here we have the parasternal short axis view, and I hope other folks are also saying yikes here. And this, I think, demonstrates something that we see commonly after surgery, if a problem's happening, is that this view is really good about seeing asymmetry. And so here you can see on the septum that there's some sort of movement going on here. But on these lateral walls near the papillary muscles, there's really not a whole lot going on. And so now I'm starting to go through, and I'm going to check the rest of the differential to make sure there's not a bleed. But I'm really worried that something with this surgery, was there some sort of issue with the coronary arteries? Are we having an ischemic injury here? What does my EKG show, and what do I do going next? But this took me all of 60 seconds, and now we can move to the next steps on our patient. Any questions about these kind of images and the qualitative analysis of this? Again, scary, not scary. So let's go to the second case. So this one is a common occurrence that we see here in Washington. So I've got an 82-year-old woman that has a known history of heart failure, reduced ejection fraction, EF of 30%. She's got some high blood pressure, and she had a relatively new diagnosis of ovarian cancer, and she's coming to get an ovarian mass removed. And so I'm trying to plan my anesthetic around her history. And this echo I find in the chart was not, it was way back in 2019, about 5 years ago. And she's coming from rural Alaska. So we're a tertiary referral center. So we get these folks, and she really doesn't have easy access to a cardiologist and to an echocardiographer. And so they still scheduled her to get a repeat TTE. And lo and behold, I dig a little bit more, and she's had a heart attack around this time of the echo, and that she got some stents. And we cannot, for the life of us, find some sort of medical history to indicate, okay, is it worse? Is it better? Does she have any sort of symptoms around with this? So I said, okay, well, let's look at the echo that we had from 2019 and see what we can find. And again, think about, okay, what is an EF of 30% going to look like for a patient? And so hopefully everybody can see all of these. So I put all the views in one so we can kind of go through each of them pretty quickly here. So up on the left, we have a parasternal long axis view. And again, things here. So looking at the septum, it does, to me, looks like the myocardium is getting thicker here, a little bit less here on the infralateral wall. And then, there's some approximation, but it's, I would argue that it's a little bit dyskinetic. It's not as symmetric as I would have anticipated. Here, the parasternal short axis really shows a much more telling picture that I would say is closer to what I would expect, this EF of 30%. So here, the myocardium is not really thickening a whole lot in this view. You can definitely see the asymmetry, and the amount of approximation that we have here is pretty poor. And that's a little scary to me. I'm expecting this patient in pre-op to be symptomatic, have shorter breath, have very low METs, so not able to walk around, not able to do a whole lot around the house. And here in our apical four-chamber view, you can really see here, again, the asymmetry and the lack of approximation is putting this into the scary window. But it's been 5 years, and clearly somebody thought that she's okay to come to surgery. But for me, I'm thinking of things, okay, what sort of monitoring do I need? Is this patient even safe because she hasn't had follow-up, or maybe she has, to go to this surgery? And the surgeon is texting me at 7 o'clock saying, "Hey, Steve, I want to do this case." The patient, she's flown, many hours from Alaska. And I explained my concerns about this echo. And I said, "Hey, things have changed. It doesn't look like she's gotten in to get this echo. There's a chance in my mind that we might not be able to do this." And he's like, "Well, what do you want me to do? Do you want me to call a cardiologist?" And I said, "No, thank you. Let me see what I can find. And if there's any difference, we might have to go that way." So here's our next images that I got that morning. And let's kind of look a little bit at this. I want to know if anybody want to take a stab at this and say, "Hey, how is this different from the views that we looked at before?"
And feel free to unmute yourselves and comment on it if you have thoughts.
Let me give a try. It looks like there's dyskinesis of the left ventricle. The walls are not approximating each other very well. Yeah, I think that's what I can see.
Good. I mean, I agree. I think there's some dyskinesia here. And I think the approximation isn't as adequate we would like. So certainly definitely in that not normal bucket. And I'll kind of go back here to the last one so that we can kind of get another view of these guys. And I think the one that I kind of look at the most here is this apical four-chamber view, just really kind of seeing the comparative nature of this approximation that I have here versus, and I'll move to this next one. Here, I think the approximation is better actually. And so certainly it looks to me that over time that she's had some recovery of her ejection fraction. And so this is an encouraging sign for me. And so obviously we're going to go to the bedside. We're going to talk with the patient. And I asked her, I said, "Hey, this is what I'm finding with this ultrasound. Tell me a little bit what you're doing." And it's very classic nature that we hear from our patients from Alaska. This patient's actually out chopping wood in the morning, and she walks around her very rural property, and she kind of tends things. So very active 83-year-old. And I said, have you ever had any symptoms since your heart attack? And she's like, "No, I see my cardiologist once a year." And, there was just no way I was going to go get to see them. So we moved ahead with surgery on this patient. But I thought this was a very nice, elegant way that we can avoid another specialist consultation, and we can be convinced ourselves that this patient is safe to go for surgery. Okay. Case 3. So this is a case that I was pretty proud of one of our residents. So I got a page at 2 in.the morning while on the CT ICU saying that they just wanted some help. So they had a post cardiac surgery patient that had a CABG, and that things seem to be progressing okay. They were on a little bit of pressors. They got some resuscitation with some crystalloid. And because they were on a pressor, the resident said, hey, let's turn off our nitroglycerin drip. And that aided in the discontinuation of the pressors. And the nurse said, hey, I did a spontaneous breathing trial and the patient's ready for extubation. And the resident went in and noticed we have a co-oximetry box because our patient had a cardiac output swan, and noticed that the CI had dropped, from something that was very normal to a much lower value. And he said, hey, wait on, I'm just curious. There's nothing else going on. I want to do a bedside POCUS really before we extubate this patient. And so, hats off to this resident for wanting to look before we advance the patient's care, given that there was a change in some of the monitors that we had for the patient. And so other information, she had it was a 2-vessel CABG, and off the bat, like our chest tubes really weren't draining out a whole lot of blood, and our post-op labs were all very normal. And these are the echoes. He basically said, hey, I need some help. And he text messaged me some of the echoes that he got before I even got to the room. And so here, what we can see, so we're going to look at kind of our 3 different things. So personal long axis on the left. And here, looking at this muscle, I would say that there's some contraction, but not a whole lot really. And there's a lot more motion on this lateral wall. The approximation, there is an attempt here, but I would say it's very poor. And you can see here the asymmetry that I was talking about. This lateral wall is moving a whole lot. Septum doesn't really look like it's moving that much. You look over here at the short axis view, and it really tells a very similar story. You can see here on this inferior wall here that there's a lot of motion. There's a lot of muscle thickening during systole, and you look up at this more anterior wall and anteroseptal wall, and there's not a whole lot of contraction. The approximation is not really doing much anteriorly, but posterior, it really feels like the heart is trying to do something. And so when I saw these immediately, I was like, oh gosh, patient just had a 2-vessel CABG. Are we having some issues with the coronary artery grafts that they just placed? And sure enough, we went over, and by the time I got to there, now the patient started to become a little bit more hypotensive. The pressors were back on, and I was able to, explain to the resident they had gotten a radial artery graft, and that's why they were on nitroglycerin to help prevent coronary vasospasm. So we turned it back on. Things sort of revolved, but ultimately the patient went down for a cath and showed that there was some evidence of vasospasm, and they were able to do some interventions to help with it. But it was very proud that the resident had the foresight to say, hey, I see a change. I'm just going to put the probe on. It's in the middle of the night. I'm in no rush. I don't need to extubate the patient, and really helped progress that patient's care. Oh yeah, here's some other views kind of this. So in this apical 4-chamber view, I think the thing that I wanted to demonstrate is that all of the views kind of tell a little bit of a different story. You might look at this and say, this actually is not that scary here on the apical 4-chamber view. There's some thickening of the septal wall. There's some more approximation here. And if I saw this, I would say, it's not 100% normal, but I kind of put that in the more mild category based on this. And the subxiphoid view here is similar, but also, also the view isn't as good and as stable as I, probably would have tried to make it. But, looking at it, you're saying, oh, it's kind of non-diagnostic. I can't really see what's going on in this image as much. Okay. Great. So here's another ICU case that I had. We had a 40-year-old gentleman that had a type A dissection, and he came into the operating room sometime earlier in that evening. He was talking with us. He said he had a little bit of chest pain, but clearly the imaging that we had showed a type A dissection. So we emergently took him to the operating room, and he basically got a hemiarch repair and came on up to the ICU. So his immediate postoperative course was pretty unremarkable. So they had normal left ventricular dysfunction or normal LV function immediately post-op. Post-op day 1 was very quick. He got extubated right away, just received a little bit of blood products. And then post-op day 2, still requiring some blood products, still a little bit coagulopathic, which post-op day 2 is a little abnormal for patients getting this type of surgery, assuming that they're getting better. But he's already doing laps around the unit. And this is a patient that, we're rounding in the unit, and he's just running laps around us. We see him go 2, 3, 4 times. And certainly that was the case on the 3rd day. And I was watching him walk as we were rounding on a different patient, and all of a sudden he really just, you could see him get winded, and he's recovering from a big cardiac surgery. The nurse said, "Hey, you've done a bunch of laps. Let's just go back to your room and we can kind of have you lie down." And then shortly after, we got a page saying, "Hey, can you come by and look at it? He's just feeling a little short of breath." So patients a couple days out from surgery, feeling short of breath, but still stable at this time. So normal blood pressure, his heart rate's a little up. I'm immediately just kind of not really even thinking about doing an ultrasound. But we kind of want to see what's going on. And so eventually we get there, and he said, I feel a little pressure in my chest. But I really think I was been pushing myself and very motivated to get around. So he was kind of brushing it off. And I said, "Well, we're here. Let's use the ultrasound. Let's see what we see." Anybody kind of want to take a stab at what they're looking at here? Abnormal, normal, scary, not scary?
Very hypertrophied, and that anterior mitral leaflet's getting, I can't tell with these, but whether it's getting into the outflow tract during systole, I can't really say. And whether there's an element of pericardial fluid at the back.
Yeah, thanks, Raj. So yeah, I'll agree. So posteriorly, you can see here there is a little bit of an effusion. So at this point, I can't tell if it's significant or not, if it's causing any sort of hemodynamic issues. The LV is very hypertrophied, so this wall is very thickened. Just looking at it in this view, there is some sort of contraction, so you can see the myocardium getting thicker. The walls are completely approximating, so they're almost touching here, and this left ventricle looks very just small to me. So I saw this view and I was like, a little bit of an effusion. This guy had a type A dissection. Am I going to find a bleed? Is he starting to bleed into his mediastinum? And are we working? Is this an early sign of pericardial tamponade? And so then I got this next view.
And Steve, if I may, will you just pop back to that view right before?
Yeah.
You can also tell, not spoiler alert, but you can also tell here that the RV at the top is really dilated. Typically it shouldn't be like 3 centimeters. It should be less than that in diastole. So you can see these hash marks on the side are centimeter hash marks. So it also looks like it's struggling, if I had to say something. And the other thing I'll just say is with the pericardial effusion, some of the ways that you know that it's not just trace, this is a silly thing, but that if you can see it throughout the cardiac cycle. So if you can only see it in systole, then it's kind of probably nothing at all. But if you can see it throughout the cardiac cycle, you know that it's more than just a trace pericardial effusion. So just a couple of fun tidbits. I was like, "Ooh, this is getting interesting."
Yeah. Yeah. Thanks, Sarah. So yeah, those things we noted, and I'll go to the next one that we saw here. And this, I think, was after I saw this image, I said, oh, wow, my differential is changing image to image here. And just like Dr. Nikravan said, that the right ventricle in the last image, and, I purposely left it out because we're not going to talk about that today, but this really was telling of, oh gosh, there's something really bad going on here. And so, yep, you'll notice that the effusion is still present here. I would definitely say that it's significant. This left ventricle is just very tiny. There's some myocardial thickening here, and it's very hypovolemic, but in the beginning, I said, okay, this is a hemorrhage. I needed to be talking to a surgeon about, whether we need more imaging, whether we need to be going back to the operating room. And when I got this view, you can see here that this right ventricle is almost 3 to 4 times the size of the left ventricle. So relatively, looking at the size in comparison to both the ventricles, it was very stark contrast. And so, we started going down the route of, okay, we have new right ventricular dysfunction. I'm worried he's having impending obstructive shock. Do we need to start looking for a pulmonary embolism here? And sure enough, despite this gentleman's, a very aggressive ambulation kind of therapy, we found that he'd had a DVT in one of his extremities that looked like it had went down. So thankfully, we caught this in time to start anticoagulation, and this effusion, while it is concerning, we were able to reduce the effusion with kind of readjusting some of our mediastinal chest tubes, but the pulmonary embolism was very real. And, it was a little bit of a close call here, but I wanted to kind of demonstrate how if you just stuck with one view, you might miss the differential here, and that really trying to get as many views as you can to really piece out the story is a very important part. Okay. So that's a couple cases that are qualitative.
Can I ask a quick question?
Oh yeah, Raj.
On the view before that.
This guy or the first one?
No, the one prior to that.
Yep.
In the left atrium, or just onto the right hand side of your screen, what are those 2 lines that are there?
I think these are probably these are probably artifact here. So he has a new aortic graft that went in from his hemiarch, and so I think that's bouncing off of the left atrium.
Yeah.
Okay, thank you.
One of the ways you can tell that it's artifact is that it crosses structures. So you see they're equidistant to each other, and it crosses like where you would anticipate the border of the left atrium to be, out into kind of never land, So they cross structures. And to Steve's point, whenever the echo hits a highly kind of reflective structure, it can cause these mirror-like artifacts that come down from it. And so you can see those 2 probably from that graft. You can see the graft is up at the top there. So
yeah, you can kind of see
this,
around the 5 centimeter mark, and then it's reflected down there at the 10. So yeah, definitely looks like in this image, if you looked at this and didn't know he'd had surgery, you're like, wow, he's got a dilated aorta. They need to do something about that. And yes, he definitely has a dilated aorta, and they did. Awesome. So let's talk about, so there's a number of quantitative ways that you can look at the left ventricle. And specifically, the question that we're going to try to answer is, what's the ejection fraction? Let's come up with a number. And in the method that I'm going to demonstrate, I kind of want to get people away from saying, okay, it's 35% versus 38%. Really, when we're doing this modality in the ICU perioperative space, we're going to look for mild, moderate, and severe. There's a number of different ways to do this. I'm just going to go over one because I don't want to kind of really get into the weeds and to get into some of the more formal measurements that some of our cardiologists do. But let's kind of move forward and talk about that. So there's a technique called the E-point septal separation. It's achieved by looking at the patient in the peristernal long axis mode, and we use M mode in an attempt to capture the motion of the anterior mitral leaflet here. And if you can see this, and in M mode, what you should get is a tracing that looks kind of like this. I kind of explained it to the residents as it's kind of a lopsided Batman looking morphology. And if you're not getting this Batman kind of morphology, then where these are the ears of his hood, if you're not getting this, you probably need to move your M mode marker back and forth until you can capture the anterior mitral leaflet. And so there are some studies that have kind of looked at this and compared this to MRI, to cardiac MRI, and found that this modality is pretty comparable in this space. And so what we're looking for really is it's asking the approximation question that we were asking when we were looking at the qualitative analysis. And so, I kind of want folks to think about this as if the anterior mitral leaflet and the heart is healthy and there's a lot of approximation, that mitral leaflet should get very close to touching the septum. And you think about it, and there's a lot of approximation going on. But if the patient, let's say the ejection fraction is very terrible and there's not a lot of contraction going on, right? That mitral leaflet is only going to be moving a little bit. And you can see that over here. So if we have greater than 10 millimeters, that's predicting an ejection fraction of less than 35%. Whereas again, if it is less than 8 millimeters, say it's 2 millimeters, that predicts a patient who has either a hyperdynamic or some sort of a normal ventricular function. And so I kind of want to relate this quantitative assessment to the kind of qualitative assessment that we were doing before. It's an old technique. I mean, they first described this back in 77, and it's really translated into our practice here today. So I wanted to give like a tracing here just so that folks can see what they're looking at. And so again, here's our E point that is going in. This is our A point. So this E point is describing the motion of the anterior mitral leaflet. And here you can see that the distance between the interventricular septum, so that's kind of this white line here that's moving in time, and the anterior mitral leaflet is very small. And so that this is an example of a normal ejection fraction in a patient with no dysfunction. And you can see here they've measured out the EPSS at 4 millimeters, which is less than that 8 millimeter mark. So here we have another image. And so I want folks to practice using a qualitative assessment, but really honing in. Let's look at the anterior mitral leaflet. Like, what is this guy doing? Is it just sitting there doing nothing? Does it really look like it's flicking up and touching the septum? That's kind of, when you see an image like this, that's usually one of the other things that my mind will look at in the qualitative analysis. And when we do M mode on this, so we try to evaluate E point septal separation, you can see here, so it's kind of hard to zone in because the mitral leaflet's kind of flapping in and out. But if you look right here, this E point is very close to the interventricular septum. And so, when we measure the EPSS, it was something like, I think 3 millimeters or so very normal. And so I wanted folks to say, hey, if I can just look at this mitral leaflet, I actually have it's a qualitative way to really say, hey, I'm really confident that this patient's ejection fraction is higher than 50%, higher than 55%. So here's another one. Here's a countering a contrast example, right? Again, we can barely see the mitral leaflet in some of these views, but what we do see, not really moving a whole lot. The wall thickness is not moving. It's a very dilated looking left ventricle. I see this and immediately say, wow, this is pretty scary. And if I look at the mitral valve and it's moving, I'm saying it is almost doing nothing. I'm expecting the EPSS to be very low and to tell the same story that I'm seeing in this view. And sure enough, you come here. So it's a little bit faded. I don't know hopefully you guys can see it on your screen. So I can measure this in time. Here's my M mode marker. And as this is going, you get it a little bit more, but look at the distance between the E point and the interventricular septum. It really does show that there's very poor function. The other thing that I wanted to note out, if I was being critical of my own images, if you look up at the way the M mode is insonating against this anterior or the interventricular septum, it's kind of an acute angle. And so you see up here that it's not really the angle that we had. If I could move this, the M mode button around or the line, I would have it more perpendicular to both of these to have a little bit more accurate. But regardless, this is severe dysfunction. This is something that's very scary, and the patient, we need something to help intervene based on, you know, the rest of the clinical picture. And so finally, I kind of want to give one of these pictures, and again, try to use the force on this image. When you're looking at this, are you happy with this image? Do you think that this patient's left ventricle is severe? Is it normal, or is it kind of abnormal? And so when I look at this, and this is unfortunately or fortunately, when somebody's not doing well, we put the probe on, and this is usually the image that we see. We're not usually gifted with an easy diagnosis. We get kind of this image that you're saying, well, there's some motion in the myocardium, not really a whole lot of approximation, but I see this mitral valve, and it seems to be moving some. And you might say, hey, this is mild. You might say, hey, this is moderate. Or some people in their minds are like, well, based on these other things, this might be severe. And so again, using one of these modalities is insufficient to really come up with a diagnosis or an assessment. And so we use a bunch of other different things. And so when I measured this, you can see here a nice, more crisp line. And if you eyeball this, you're saying, well, there is some distance between the interventricular septum and the mitral valve. But when I actually ran the numbers, our EPSS was 10.2. So just a hair close. And the reason why I was initially falsely assured that, like, hey, this is moderate at worst, I see a lot of motion in the mitral valve, is that the ventricle's dilated. And so the distance that it's actually going is it was more than, or the gap, excuse me, between the mitral valve and the interventricular septum was more than when I was initially looking at it. So getting that quantitative measurement actually helped me make the diagnosis where I could say, it's still in the moderate category, but it is so close to severe. And some of the other things that I'm thinking, I need to get more studies. I need to do an intervention now to kind of help these patients. So those are the cases that I had. I just want to thank everybody for kind of doing some of these with me. And I hope that you guys, the takeaway is that you're equipped a little bit more aptly to assess the left ventricle. Again, kind of to summarize, is the big three things that we're looking for is thickness of the myocardium, approximation of the left ventricular chamber, and then is there symmetry or asymmetry? And then again, with the quantitative assessment, using EPSS as a supplement to really confirm the diagnosis, if you have this indeterminate view and you're saying, well, I really don't know, to better equip you to saying, hey, this is, the ejection fraction is closer to 30 than it is to 50, and I'm going to do something different about that. Thanks, and I'll take any questions if folks are curious.
Steve, thank you so much. That was really amazing. I have a question for you. So do you have like a suggestion on like what times you can or can't, what times you can't use E-point septal separation, for example? Like when is it not the best modality?
So it's a great question. I'd say that, the first time when we don't really see this is if you can't get the view, if the mitral valve really is having issues, and the angle of insonation isn't able to really kind of hone in on that valve. Again, the easy things, if you've had mitral valve surgery, if the patient has some sort of like a mitral valve prolapse, if there's a very, very dilated left ventricle or a left atrium, that can do that as well. Those are kind of the things that I think about.
Yeah, that's really cool. I really liked when you made that point. It was like maybe not in line, but also the separation was so wide that it didn't really matter that it was in line or not, which is great. The other question I have for you is, do you have any like recommendations to the group on how they can get better with their eyeball testing? Like, what things did you do at the start to help kind of hone your eye?
Yeah. So any medical skill, in medical education and adult education, the answer that we've always found very consistently is just reps. And so that's kind of what I was hoping in the beginning. Is a lot of people, the barrier to doing POCUS is this: I'm not good enough yet. And I really want to encourage people, just put the probe on the chest, even if you have no idea what's going on. When I was a fellow, one of my a recent grad who was a very, kind of a mentor to me, saying, "Hey, Steve, you're going to go through training and you're going to have some downtime. Post-op patients will come up and they're going to be healthy. They're not going to need your help. They're just going to go through the system." And they said, what I did is every patient who came up and had a surgery, just put the probe on, just see what it is. If you're expecting normal, look at normal. And you'd be surprised how often sometimes you really find something that's a lot different. So reps is the biggest thing. I find it helpful is when I kind of get these indeterminate ones. So if I look at it and I'm like, I'm 100% sure this is a very normal echo. This patient is walking, talking, they're ready to go home. And the easy ones too are the ones that are severely abnormal. I think the thing that really helped me is this indeterminate. When I looked at it and I'm like, something's weird, I don't know what it is, I would go back and review the formal echo from the echocardiographer, from the cardiologist, what that read was. And they don't often comment on whatever I thought was strange, but sometimes they do, and they say, "Oh, I note like Dr. Nathwani was talking about, like, what are these artifacts?" Sometimes they're in the report. There's a little artifact where you can really say, "Hey, oh, okay, I don't need to worry about that. That's not a finding. There's not a foreign body in the left atrium. That's a normal kind of thing." So those are the kind of some of the things that I would do.
Thank you.
Yep.
Steve, can I ask a quick question?
Yeah.
Whenever I've thought about E-point septal separation, to me, it's like the wrong way around of thinking, but I always think of it as a kind of start of diastole. So it's like a relaxation phase for that left ventricle, and yet we're using it as a marker of systolic ejection fraction or squeeze. And that, to me, I don't quite understand why we do that.
So the question is, how do I think about E-point septal separation, or is the question is why does it work?
Yeah, more like, why does it work? I'm thinking of this as a diastole phase, and yet we're using it as a marker of ejection fraction or a marker of squeeze.
Yeah. So I think that's a great question. And so I'll kind of clarify to the group is that, if you're looking at an ejection fraction, blood leaving the left ventricle, the mitral valve has to be closed. You got to go out the aortic valve. So why aren't we doing measurements on the aortic valve? This mitral valve doesn't make a whole lot of sense. And the way I think about it is that really all the equations of ejection fraction in more quantitative methods are looking at differences in systole and diastole. And so you're right, the cardiac cycle that they're looking at is looking from the relationship of the left atrium and the left ventricle, rather than the relationship of the left ventricle and the aorta, where the blood is actually leaving. But I still think we can get really valuable information from saying, okay, in diastole, this is what the mitral valve's doing. And then in systole, this is the response to the filling of the left ventricle. And that's kind of where you get that. So I think the cardiac cycle is a circle, and I don't think your thought process is wrong. I think maybe the more intuitive way is saying, hey, we're just starting from rather than starting, because the ejection fraction is the beginning of systole to the end of systole, how much stroke volume do they have? And I think your thought process is, okay, I'm going to start more in diastole or end diastole and work my way backwards. It's like one of those math problems where you show your work and maybe the work's wrong, but you still get the right answer. I think how you're doing it is not incorrect at all.
And if I can just kind of add to that too, to Steve's point, and yours, Raj, this is a diastolic assessment. But what you think about is when a patient has poor LV contractility, their filling pressures are elevated. So the left ventricular end diastolic pressure is elevated in these patients typically. So that what happens is the mitral valve opens to fill the LV and the pressures equalize like that, and then it closes. So it can't open all the way to hit the ventricle like it would in a normal patient. It just kind of like falls open briefly and then the pressures equalize because they're high, right, in the LV, and then it closes. And that's one of the reasons why it works as an assessment of LV function, even though it's done in diastole, if that makes any sense.
Yeah. Can I also add there? Basically, what I feel is that it is what EPSS is, endpoint septal separation, is the distance between the interventricular septum and the tip of the mitral valve. So as the contractility increases, the interventricular septum will move more towards the mitral wall. Similarly, the mitral wall will also move. The tip will move because of the better contractility of the myocardium. It will move towards the interventricular septum. So it is a distance which will definitely decrease as our contractility increase. So I think it is quite a good parameter that way.
Yeah, I totally agree. Well, if there's no other questions, I want to thank everybody again for joining us on, another one of these global this global consortium that Dr. Nikravan has set up. I think, what's the next topic, Sarah?
I'm going to be talking, I think, on the next topic on RV assessment, which, as you know, is totally my jam. So, so yeah, that's why Dr. Vanhoy didn't focus too much on the RV on this talk, so that, we could focus on the LV, and then I'll bring the RV in March when we come back together.
Awesome.
Dr. Vanhoy, thank you so much. This was an excellent talk. I'm super excited that we had the opportunity to have you present here today. We'll get this video released and up on our YouTube channel so that everyone can view it, and really want to thank you for your time today.
Awesome. Thanks for having me.
Yeah, thank you. Thanks everybody for joining. Bye.
Thank
Bye.
you.
Bye.
It was an amazing session.
Thanks, Kapil. See you later.
Bye.